Today we will begin our lectures of the head and neck. In this particular video, we will give an overview of the neck, discuss important landmarks, and then briefly talk about ways that we describe or ways in which the neck is broken into different regions in terms of its triangles and columns. And then we'll also talk about the muscular groups of the neck. What we refer to as the neck extends from the neurocranium and visceral cranium located anteriorly all the way down to the thorax. So it goes from the mandible, shown here, in the posterior skull, all the way down to the level of rib 1. It includes the larynx, which is this region that is involved in voice production anteriorly. Now, for the sake of our discussion, I'm going to use a colored picture, and this colored picture can be found in Grant's Atlas, page 8.2. So what I've tried to do is give you the page numbers of your notes or a reference for the images that I use so that you will be able to find it. So again, in the neck, we're talking about the larynx, which is that part that is responsible for voice production. It extends from the hyoid here to the trachea, shown here, and is located anterior to the bodies of C3 through C6, the vertebrae C3 through C6. We're also referring to in the neck the pharynx, and the pharynx is divided into 3 regions, the nasopharynx, the oropharynx, and the laryngopharynx. Is shown in this image in pink. It goes from the base of the skull, superiorly, all the way down to the esophagus. It is approximately at the level approximately at the level of the cricoid cartilage. Posterior to that is this space called the retropharyngeal space. And so in order for you to kind of understand what this retropharyngeal space is, I need to briefly talk about the columns of the neck and these fascial spaces that are created to allow the organs of the neck and the bony skeleton to move relative to each other. The retropharyngeal space is between these layers of fascia located in the neck and represents a clinically important area for the passage of infection, for instance. So the neck can be divided. It is encapsulated in these different layers of fascia. And you can see this green fascia that splits and goes around trapezius and then comes back together again and then splits again to go around the sternocleidomastoid. This layer of fascia indicated by the green going all the way around the outside of the neck is the deep layer of investing fascia. Also, going around the viscera in the anterior portion of the neck is this kind of purple layer of fascia, and this is called the pretracheal fascia. There's an extension on the posterior aspect of it called the buccopharyngeal fascia, and you can see in this cutout of the layers here that the buccopharyngeal fascia is shown here in purple, and then finally you get to these white spaces between the buccopharyngeal fascia in purple and another fascia layer called the prevertebral fascia. This prevertebral fascia is indicated in this image below by the orange line. So the prevertebral fascia goes around the epaxial muscles and also the vertebral column, and it's shown here. So again, between this buccopharyngeal fascia in purple and this prevertebral fascia shown in orange, is this space called the retropharyngeal space. It's subdivided by a fascia layer called the alar fascia, and there is some controversy or at least inconsistency as what is considered this retropharyngeal space, this clinically important space. And so for our purposes, we will, as your pictures define it, as this space posterior to the alar fascia and anterior to the prevertebral fascia. But it is important to note, for you to note, that in some schools and some texts also refer to this region or this space immediately anterior to the alar fascia, yet posterior to the buccopharyngeal fascia. Also, they also consider this a part of the retropharyngeal space. It is that space, this retropharyngeal space, extends all the way from the base of the skull, shown here, all the way down to about the level of T4. That is important because it represents a passageway, for instance, for a paratonsillar abscess that might invade the posterior pharynx, for that infection to then go all the way down to the superior mediastinum in the thorax. Again, the neck can be divided into these columns by these fascial layers, making a musculo-osseous column or a visceral column. And we'll talk about those some more as we go along. And this just is a blow up of the picture that we saw on the previous page, again highlighting that retropharyngeal space between the buccopharyngeal fascia, alar fascia, and the prevertebral space. So notice that this color, this is a color picture. This is part of your on Grant's Atlas, but it's also present in your notes, pages 22 to 23. When you see these blue backgrounds on the slides, it usually indicates that it's something that I've moved into a different area, or that it is a picture not listed in your notes, such that it helps me to explain or tell the story of what we're talking about. Here again is the investing layer of deep cervical fascia, indicated by the green line splitting, going around the trapezius, going around the sternocleidomastoid, and investing the entire neck. The purple line here indicates that pretracheal fascia, and the pretracheal fascia goes around this viscera, but also the posterior part of this pretracheal fascia is what is the buccopharyngeal fascia. The orange line here indicates this prevertebral fascia, and then the carotid fascia, indicated by red here, invests the carotid arteries and the internal jugular vein, as well as the vagus nerve. So from medial to lateral, it's carotid artery, vagus nerve, and internal jugular vein. The carotid sheath, or this fascial layer, is made up of the pretracheal fascia in purple, the prevertebral fascia, and the investing layer of fascia. And then it subdivides this space between the buccopharyngeal fascia and prevertebral fascia to what we're calling the retropharyngeal space. Again, acknowledging that some sources will say that this region anterior to this alar fascia, yet posterior to the prevertebral fascia, are also a part of the retropharyngeal space. Notice the location of the sympathetic trunks in this area, and that'll become important as we continue discussing what's going on in the neck. The pharynx that I mentioned earlier has three parts. This nasopharynx, which is more superior, the oropharynx, which is posterior to the oral cavity, goes from the soft palate all the way to the superior aspect of the epiglottis, and then going from the epiglottis to the esophagus is the laryngopharynx. Your notes say that the food and air passageways crisscross in the neck. And what it means is that when you ingest a bolus of food, it's pushed posteriorly and enters into this pharynx to gain access to the esophagus. And the nasal passageways, the passageway for air then goes anteriorly, such that the air then goes through the larynx and eventually the trachea to gain access to the respiratory system. Some major landmarks of the neck include the external occipital protuberance, and you've seen that now that you were introduced to that at the very beginning of your back dissections. Also notice the mastoid process of the temporal bone and the styloid process of the temporal bones. These are going to be representative of, these are going to be important because they represent superior attachments for quite a few of the muscles in the neck, and so we will refer to them often. The mandible is shown here with the angle of the mandible and the ramus of the mandible. And then we have inferior to that is the hyoid bone. The hyoid bone is unique in that there are no bony articulations for the hyoid bone. Rather, the hyoid bone is held in place by the muscles that are acting on it and attaching to it both above and below the hyoid, such that it can move the hyoid bone up and down or protrude it and retract it as appropriate for speaking, for swallowing, and so the hyoid bone, again, is an important landmark. That bone is at the level of about C3. If there is a strangulation victim, the pharynx collapses because of the damage to the hyoid bone. It can result in dysphagia, so the problem swallowing. It can result in painful swallowing, coughing up blood, and then pain upon neck rotation, as well as crepitus when you touch it. Inferior to that is the thyroid cartilage. The thyroid cartilage is about the level of C5, C4, C5 right here. The thyroid cartilage is open posteriorly, and it sits on top of the cricoid cartilage. The cricoid cartilage forms a complete ring, and the thyroid cartilage kind of tilts on a hinge on the cricoid cartilage during phonation, and is important in the movement of the vocal cords within the larynx. Notice here are tracheal rings, and then other important landmarks is the sternum, the jugular notch of the manubrium, and also the clavicle. A clinically important feature that I want to bring up here is Eagle syndrome. And so that can result from an elongated styloid process such that it's too long, or there is a ligament, a stylohyoid ligament, that, as you might imagine, goes from the styloid process to the hyoid bone. that gets calcified. So if the stylohyoid ligament gets calcified, you might imagine that it makes the movement of this hyoid bone during swallowing and phonation very difficult. In addition, the styloid process can impact the structures that are located in this part of the neck. So the common carotid arteries, as well as some nerves, including the glossopharyngeal nerve, which is closely associated with this styloid process. You can see here in the radiograph, here's our hyoid bone, and then the styloid process usually ends more superiorly, and this star indicates a calcified stylohyoid ligament that is responsible for Eagle syndrome in this particular patient. So as we take a look around the neck, right, I've described to you briefly those columns, and I will talk more about that. But another way that we can describe or orient ourselves to structures in the neck would be to use triangles, to describe things in terms of their triangles. What I'm showing you here and what I've drawn in here is the platysma muscle. And the platysma muscle is a muscle of facial expression that is inside the subcutaneous tissue in the neck. It's very superficial, and when you dissect it out, it is going to be a very thin sheet of muscle over the anterior aspect of the neck. If you go too deep, go too deep into the subcutaneous tissue, you will miss it. So you want to be very careful in your dissection in that point. Once you reflect the platysma muscle, you will notice very closely attached to the deep surface of the platysma, the external jugular vein, excuse me. The external jugular vein travels over the sternocleidomastoid and then dives deep to the posterior border of the sternocleidomastoid near the clavicle. So the sternocleidomastoid muscle is here. Again, if you are too deep when you are reflecting the platysma superiorly, you will also remove the external jugular vein. Once we have exposed the area, notice that I've drawn in two different colored triangles. One posterior to the sternocleidomastoid and represents the posterior triangle in blue, as well as the anterior triangle, which is shown here in the orangish color. The sternocleidomastoid, which divides the areas, is responsible in part for flexion of the head and neck, and torticollis is one of those clinicals that you'll want to pay attention to as you are looking at your clinicals for this particular section. In the posterior triangle shown here, I want you to recall the image of the green investing layer of deep cervical fascia that we saw in the image of the columns in previous slides. And remember that investing layer of fascia encloses the trapezius and then combines again to then go around the sternocleidomastoid and meet anteriorly. So the roof of this posterior triangle is that green layer of investing cervical fascia. This posterior triangle is also subdivided by the omohyoid muscle, and it goes from the shoulder, omo, to the hyoid bone. It's a two-bellied muscle containing an upper belly or a superior belly and an inferior belly. And then there is a tendinous connection that changes the torque of this muscle to change the direction of the pull that lies deep to the sternocleidomastoid. This lower belly of the omohyoid muscle subdivides the posterior triangle into an occipital triangle named for the occipital artery that travels near the apex of this triangle, and a supraclavicular triangle that is inferior. Again, so this investing layer of fascia encloses some structures in it, and there are going to be some structures that pierce it, as well as some things that run through it. The floor of that triangle will be four muscles, well, not four muscles, muscles in that, some of which you've seen: the semispinalis, the splenius muscle, the levator scapulae, and then the posterior, middle, and anterior scalenes also together form the floor of the posterior triangle. The spinal accessory nerve, which exits the jugular foramen deep to the superior attachment of the sternocleidomastoid. It also travels through this posterior triangle to get to trapezius. And so you'll also see the spinal accessory nerve, cranial nerve 11, on its way to the trapezius. And we talked about that when you guys visited the prosected cadavers. There are also cutaneous nerves that are going to come out of this posterior triangle that we will talk about a little bit later. And because of the anterior and middle scalenes also being a part of the posterior triangle, you can also expect portions of the brachial plexus as well as the subclavian artery and vein to be at the lower border of the posterior triangle. Now, the anterior triangle is subdivided by the superior belly of the omohyoid, as well as the anterior and posterior bellies of the digastric, shown here, and the stylohyoid muscle, which conveniently tells us what its attachments are. Okay, and so just like we saw for the omohyoid, there's a tendinous attachment that then changes the direction of the torque, changes the direction of the pull for this digastric muscle, this two-bellied muscle in this area. Now, when we talk about these triangles, we can then talk about more specifically or locate specific structures that are going to be in these particular areas. Our infrahyoid muscles, as well as our anterior jugular vein, are found in the muscular triangle. The carotid triangle, shown here, contains, as one might expect, the carotid arteries, common carotid and external carotid arteries. And because of its location in the carotid sheath, you may also get a portion of vagus nerve in that particular area. The digastric triangle, also referred to as the submandibular triangle, largely contains the submandibular gland and lymph nodes, and then a portion of the facial artery as it goes travels over the posterior border, the inferior border of the mandible to gain access to the face, will also be present here. The submental triangle formed by the anterior bellies of the digastric on both sides of the face, contains submental lymph nodes. And when you see the word mental, you're looking, it usually refers to the chin. So submental triangle refers to that particular area. Now, I mentioned that the infrahyoid group of muscles lie in this muscular triangle, and that's shown in this image over here, where the infrahyoids have been circled or highlighted by purple. Okay, and so medially and anteriorly, you have the sternohyoid muscle that goes, as one might imagine, from the hyoid bone to the sternum. Deep and slightly lateral to that, you see the sternothyroid muscle, and it's shown on this left side of the image. It attaches to the thyroid cartilage and the sternum. The omohyoid muscle we've talked about, which is the same one on the left side of the slide, that bisects the posterior triangle and a portion of the anterior triangle. Omohyoid is shown here, and it is also an infrahyoid muscle, as is the thyrohyoid muscle, which goes from the hyoid to the thyroid cartilage. Now, it's easy to remember what innervates the infrahyoid muscles, because all of them, except the thyrohyoid muscle, are innervated by a loop of nerve that is made of cervical nerves C1 through C3. So C1, 2, and 3 form a structure called the ansa cervicalis, and the ansa means loop. There are two, each, I guess, end or arm of the loop can be referred to by different names. So the descendens hypoglossi is the portion of the ansa cervicalis that descends with the hypoglossal nerve, which is shown here. The hypoglossal nerve is cranial nerve 12, and it goes on to innervate the intrinsic and extrinsic muscles of the tongue. The portions of the ansa cervicalis, however, are not part of the hypoglossal nerve. They are, again, from cervical nerve C1 through C3, forming the descendens hypoglossi and the descendens cervicalis, so the part that just descends with the neck, to form the ansa cervicalis. And you can see here branches going to the omohyoid, the sternohyoid, and the sternothyroid. The thyrohyoid muscle, which is a part of the infrahyoid group, is not innervated by the ansa cervicalis, but is innervated by fibers of C1 that are not a part of the ansa cervicalis. The muscles I've indicated in green are part of the suprahyoid group of muscles. Suprahyoid meaning above the hyoid bone, which I've shown here. So the digastric muscle, anterior and posterior bellies, the mylohyoid muscle, and the stylohyoid muscle are all shown on this picture. And there's one additional muscle that's not shown, which is the geniohyoid. And so you'll see that in later slides. The suprahyoid muscles have different innervations, and so it's not as convenient to group them all into one category, but the mylohyoid is innervated by cranial nerve 5, which is the trigeminal nerve. The trigeminal nerve is divided into 3 divisions, and only the 3rd division has motor innervation. So whenever you are referring to the trigeminal nerve and its innervation of a particular muscle, then you know automatically that we're talking about the third division of the trigeminal nerve, which is the mandibular division. The geniohyoid, genio meaning chin, and so geniohyoid goes from, is innervated by C1 fibers that are not a part of the ansa cervicalis, just like our thyrohyoid was in our infrahyoid group. The stylohyoid muscle is innervated by the facial nerve, which is cranial nerve 7, shown here. And then the digastric muscle is innervated by the anterior and posterior bellies are innervated by two different nerves. The anterior belly is innervated by the trigeminal nerve, the third division, which is the mandibular division, and the posterior belly is innervated by cranial nerve 7, which I just told you was the facial nerve. In this image, in your notes, again, I want to just draw your attention to those muscles that I told you that make up the floor of the posterior triangle, namely our semispinalis, our splenius capitis, our levator scapulae, posterior scalene, middle scalene, and anterior scalene. And then you see the inferior belly of the omohyoid separating our posterior triangle into two smaller triangles. On the anterior triangle, you had our sternohyoid here, our sternothyroid here, and then we also see a bit of our pharyngeal constrictors, as well as our digastric, our posterior and anterior belly, and mylohyoid, and geniohyoid is shown deep to here, all making up the floor of that anterior triangle. There is a difference in the attachment of the scalenes. Notice how the posterior scalene attaches to rib 2, whereas the anterior and middle scalene attach to rib 1. That becomes important as you think about the location of the brachial plexus, and if, for instance, there is a cervical rib, which is an elongated transverse process of C7, okay? And so that becomes clinically important, the relationship between that transverse process, that elongated transverse process that's present in a cervical rib, and the location of the brachial plexus relative to the scalenes, the middle and anterior scalenes. We've already kind of talked about these things, so I won't bore you with that again. The extrinsic muscles of the tongue and intrinsic muscles of the tongue, I've already told you, are innervated by the hypoglossal nerve, which you saw on previous slides when we discussed the ansa cervicalis. Remember that the descendants hypoglossi of the ansa cervicalis, that portion descends with the hypoglossal nerve, but is in fact not a part of the hypoglossal, that part of the ansa cervicalis is not a part of the hypoglossal nerve. The only exception to this group of muscles which represent extrinsic muscles of the tongue is pallida glossus, and it's innervated by cranial nerve 10 or 11, so that's vagus or accessory nerves. And we'll talk about that as we talk about the tonsils and the palates later. Genioglossus, hyoglossus, and styloglossus attach to the tongue and either the chin, the hyoid bone, or the styloid process, respectively. And so it's easy again to think of these as having the intrinsic and extrinsic muscles of the tongue. All are innervated by hypoglossal cranial nerve 12, with the exception of palatoglossus. Review the epaxial muscles of the back. So we've already now talked about the lateral aspect of the neck and a little bit about the anterior aspect of the neck. But the epaxial muscles and hypaxial muscles, they're going to make up the posterior part of the neck. Also review the suboccipital triangle and its contents, its borders, what's going through it, and etc. Now, within the prevertebral fascia lies this group of muscles that only is made up of the longus capitis and the longus colli. These muscles are considered prevertebral muscles, and they sit immediately anterior to the anterior longitudinal ligament and the bodies of the vertebrae. And so together, the longus capitis and longus colli make up the prevertebral muscles. They are innervated by anterior rami of C1 through C3. So the longus capitis is innervated by anterior rami of C1 through C3. And the longus colli, colli meaning neck, the longus colli is innervated by anterior rami C2 through C6, which makes sense because you see how long this muscle is relative to the longus capitis here. I've also taken the time to put the innervation of the scalenes, posterior scalene C7 through C8, and the anterior scalene C4 through C7, as well as the middle scalene C3 through C7. Superiorly here, you notice the rectus capitis lateralis and the rectus capitis anterior. Those are innervated by anterior rami C1 through C2. So if we take a look at the bottom of the skull, notice again our longus capitis attaching anterior to the foramen magnum. This is anterior, this is posterior, and here's our foramen magnum. The longus capitis attaches anterior to that, as does the rectus capitis anterior. And then, although it was difficult to differentiate on the previous slide, the rectus capitis lateralis does in fact attach laterally, as the name implies. While we're on this slide, though, we can go on and take a closer look at the internal carotid artery entering the carotid canal and the jugular vein, which is exiting the skull through the jugular foramen, accompanied by the spinal accessory nerve, vagus, and the glossopharyngeal nerve. So that's cranial nerve 11, 10, and 9, respectively. I've also colored in the facial nerve, and if you'll recall that the facial nerve innervated, for instance, the posterior belly of the digastric and the stylohyoid muscle. And this is the facial nerve exiting the stylomastoid foramen. So the mastoid process is here, styloid process is here, and so the stylomastoid foramen is this foramen right here between the two structures. As we move on to the second part of this video, I do want to let you know that there is a chart of the skull and its foramina and the contents of each of those in your notes that can be found in your notes. And I can, I'll look up the page number for those for that chart in this version of the notes and let you know. And so in this next part of the video, I want to talk about the nerves, arteries, veins, and lymphatics that are going to be found in the neck. So let's just orient ourselves here for a second on this image and remember that the mastoid process is located about right here where my pointer is. And the sternocleidomastoid muscle then moves inferiorly and anteriorly across the neck. The ansa cervicalis, which we've talked about, that's made of cervical nerves C1, 2, and 3, is shown here in red. And remember that the ansa cervicalis innervates the infrahyoid muscles with the exception of the thyrohyoid. The thyrohyoid. So the thyrohyoid muscle is innervated by C1 fibers that don't join that loop, but then travel with the hypoglossal nerve, which is here, for a period of time. And then those C1 fibers innervate the thyrohyoid and then also the geniohyoid, which is one of our suprahyoid muscles that we discussed before. The hypoglossal nerve innervates the intrinsic and extrinsic muscles of the tongue with the exception of palatoglossus. So all of that is review for you because we've talked about that previously. So the cervical plexus is a series of loops formed by these cervical nerves that go on to innervate multiple structures within the neck, as well as providing cutaneous innervation of the neck. The cervical plexus also includes the phrenic nerve, which is made up of C3, C4, and C5. So C3, 4, and 5 keep the diaphragm alive. So the phrenic nerve is made up of those three roots. In addition, we talked about the spinal accessory nerve, shown here, going through the posterior triangle, emerging deep to the superior attachment to the sternocleidomastoid, and then traveling through the posterior triangle to then innervate the trapezius. If you'll recall, C3 and C4 from our cervical plexus are responsible for proprioceptive innervation for trapezius. There are also these cutaneous branches that emerge posterior to the sternocleidomastoid and then go to different spaces on the lateral neck. The first is the lesser occipital nerve. And the lesser occipital nerve, shown here, travels up the posterior border of the sternocleidomastoid, and that's going to be the easiest place to find that, on the posterior superior border of the sternocleidomastoid as it ascends. The great auricular nerve is just below that, and just as the name implies, is going over here towards the base of the ear. Here's our great auricular nerve. And then our transverse cervical nerve emerges from the posterior border of the sternocleidomastoid to travel transversely across often across the sternocleidomastoid to provide sensory innervation to the lateral and anterior neck. The supraclavicular nerves include a medial, intermediate, and a lateral branch. And each of those, again, provides sensory innervation to the shoulder. Interestingly, you can get some referred pain from via the phrenic nerve to these supraclaviculars due to the involvement of C3 and C4 in the supraclaviculars. The cervical plexus includes the muscular branches that I've colored over here, which are the ansa cervicalis, which goes to the infrahyoids except thyrohyoid, the geniohyoid, the diaphragm via the phrenic nerve, longus colli and longus capitis, so those cervical nerves C2 through C6 and C1 through C3 respectively. The sternocleidomastoid is innervated by the accessory nerve, but C2 and C3 augment the spinal accessory nerve innervation of sternocleidomastoid, just like C3 and C4 augment the innervation of the accessory nerve with trapezius. The dorsal scapular nerve is augmented by branches, again, of the cervical plexus. So C3 and C4 augment the dorsal scapular nerve in that respect. The sensory branches are these white branches that I've shown, the lesser occipital going up the posterior border of the sternocleidomastoid, the great auricular nerve towards the base of the ear, the transverse cervical, and then the supraclaviculars. And you can see the roots of each of those listed here. So I'm showing you once again those cutaneous branches. They emerge at a point about midway the posterior border of the sternocleidomastoid. So here's sternocleidomastoid. That point is called the nerve point of the neck. So if there is a need to anesthetize the lateral portion of the neck, the injection of anesthesia at this posterior border will reach these cutaneous branches via the nerve point of the neck. Notice also the external jugular vein traveling across the sternocleidomastoid. And there is sometimes a connection between the transverse cervical branch of the cervical plexus with the cervical branch of the facial nerve. Remember, the facial nerve is cranial nerve 7. And so sometimes there is a connection between these two branches in the anterior neck. Another clinically important feature is the fascia. No, I'll talk about that later. Yeah, I'll talk about that later. All right, so here is a picture from Rowan, and you can, I've colored in again these cutaneous branches of the cervical plexus with the lesser occipital, great auricular, transverse cervical, and then the medial, intermediate, and lateral branches of the supraclaviculars. Remember that these branches of the cervical plexus, these are anterior rami or ventral rami, as opposed to the dorsal rami that make up the greater occipital, the third occipital, and these cutaneous branches on the posterior aspect of the neck. The anterior face, however, is via the branches of cranial nerve 5, which is the trigeminal nerve. Remember that I told you that when we've seen so far the motor innervation by the trigeminal nerve, that all the motor innervation comes by this third division of the trigeminal nerve, that is the mandibular nerve. All three, however, are responsible for sensory innervation. So V1, which is the ophthalmic nerve and its branches, V2, which is the maxillary nerve and its branches, and mandibular nerve, all are responsible for sensory innervation to the face as shown. And so sensory is all three divisions of the trigeminal nerve, whereas motor innervation is only by that third division, which is the mandibular division. In this slide, again, it's talking about the ansa cervicalis, and we've talked about that, so I won't bore you with the details, other than to point out that both C1 and C2 tend to participate in this descendens hypoglossi. So this arm of the ansa cervicalis that descends with the hypoglossal nerve. And then C2 and C3 come together to form this descendens cervicalis, which is just the other arm of the ansa cervicalis. There are other branches that participate, but they are not a part of the loop. So for instance, the meningeal branches shown up here, which are going external to the meninges, ascending in the neck, external to the meninges, and then you have the C1 fibers that innervate the geniohyoid and the thyrohyoid that again are also not part of the ansa cervicalis. When you do this dissection, recall that, so we're going to be in the anterior triangle, particularly in the carotid triangle of the anterior triangle. You will find those ansa cervicalis branches that are going to the infrahyoid muscles shown here. The length of that loop varies from person to person. So you may see a short one in some bodies and a long ansa cervicalis in other bodies. Regardless, it's closely associated with the internal jugular vein, which can be found in the carotid sheath. So you have that fascial layer surrounding it, deep to the sternocleidomastoid muscle, which is shown here. And so I want to remind you of all of this fascia that you're going to see, and then the walls of this internal jugular vein are going to be thin, and the internal jugular vein is also rather large. Okay, but the orientation of the loop relative to the internal jugular vein may be in any of these different orientations, where one portion may go anterior to the vein, or both portions may be posterior to the vein. In this image, I want to talk about sympathetics, and so we'll talk a little bit more about that, as well as the relationship between those structures. So notice on this right side of the image, this white fascial layer here, that is prevertebral fascia. And that prevertebral fascia has been cut away on the left side of the image here. Sitting on top of the prevertebral fascia is the sympathetic chain. And I want to encourage you to look at that cross section where we discuss the different fascial layers in the neck, to orient yourself about the sympathetic chain and its relationship, for instance, to the retropharyngeal space. So sitting anterior to the prevertebral fascia are these sympathetic ganglia, cervical sympathetic ganglia. Now recall that all of the sympathetics originate in the IMLCC, the intermediolateral cell column. So all of those they originate T1 to L2. So sympathetics in the neck and ascend in the face. They enter from the IMLCC and then enter into the sympathetic chain and ascend to the superior, middle, or inferior cervical ganglion. They synapse there, and then from there, postganglionic sympathetics can then travel to targets in the face, for instance, or in the head, uh, via blood vessels or other nerves. So they accompany those in order to get to their targets. Now, there are no sympathetics in the gray matter in the brain, but those in the face or associated with the eyes, for instance, they get there by synapsing in those cervical ganglia, and then postganglionic sympathetics then ascend and then move to their targets via the arteries that are going that way or other nerves. When we talk about the superior the superior cervical ganglia, this is the largest and most pronounced of the cervical ganglia. It is at about the level of C1 and C2, cervical vertebra, C1 and C2. It's the superior extent of the sympathetic trunk, posterior to the internal carotid artery, and it sends branches to the internal carotid artery, for instance, and the external carotid artery to form plexuses to get to targets in the head. It also sends the superior cardiac nerve back down towards the cardiac plexus. The middle cervical ganglia is much smaller than the superior cervical ganglia. It is about the level of cervical vertebrae C6. And it then sends cervical spinal nerve C5 to C6 via gray rami, and it sends this middle cardiac nerve back down to the cardiac plexus to participate in a plexus with parasympathetics, so sympathetics and parasympathetics together in the plexus to facilitate innervation of the heart, for instance. The inferior cervical ganglion is often absent. If it is present, it is usually anterior to the neck of rib 1 and at about the level of C7 if it is present. But often it fuses with the first thoracic vertebrae to form the stellate ganglia or the cervical thoracic ganglion. You'll find that the stellate ganglia near the origin of the vertebral artery, immediately posterior to that. And then there's an inferior cardiac nerve that then travels to participate in the cardiac plexus. So a stellate block would be the injection of anesthesia at that cervical thoracic or stellate ganglia in the event that there is a procedure, for instance, that needs to be done. Let's see, what else do we have here? So we have the vertebral artery. We also have the thyrocervical trunk and the branches that result from that, namely the inferior thyroid artery, the ascending cervical artery, and the transverse cervical or dorsal scapular artery and the suprascapular artery. And we will talk some more about that. And so again, this sympathetic trunk is sitting, the sympathetic trunk is sitting on top of the prevertebral fascia, which lies anterior to the longus capitis and longus colli, those prevertebral muscles that we've already talked about. So notice here the location of the sympathetic trunks in this retropharyngeal space, immediately anterior to the prevertebral fascia, as we've shown, and then posterior to the alar fascia and the buccopharyngeal fascia. Notice also the close association of the carotid arteries and internal jugular veins in the carotid sheath to the sympathetic trunk. So for instance, if there is a carotid aneurysm, it could impact the sympathetic trunk on either side, or infections that maybe impact the retropharyngeal space could also impair the sympathetics to the head and face. One such problem with the sympathetic, so impacting in this case unilaterally, impacting sympathetics, it causes Horner syndrome. And in Horner syndrome, the lack of sympathetics results in a partial ptosis, which is eyelid drooping, miosis, which is pupillary constriction, anhidrosis, lack of sweating, and flushing. And so those things result because those are parasympathetic activities. And so because there is a lack of sympathetics to antagonize the parasympathetics, what you see in that individual really is it looks like the parasympathetics have taken over, so to speak. So why do you get the ptosis? Because you're thinking, well, what does sympathetics have to do with the eyelids? There is a small muscle called the superior tarsal muscle, which is located here, this small smooth muscle here, located near the levator palpebrae superioris. So that muscle, that levator palpebrae superioris, is here. And there's this small smooth muscle, the superior tarsal muscle, that connects to the tarsal plate here. And so if the sympathetics are not engaged, then that causes a relaxation of the superior tarsal muscle and the eyelid to then droop. And so that's where that comes from. So that ptosis, characteristic of Horner syndrome, is due to the sympathetic or innervation of the superior tarsal muscle. All right, in terms of parasympathetics, that's largely due to branches of the vagus nerve. And so the vagus descends in the carotid sheath between the carotid artery medially and the internal jugular vein laterally. And what we see is that the branches of the vagus participate with those cardiac nerves from the sympathetic plexus to create a plexus that contains both sympathetics and parasympathetics. And then they will either work to speed up or slow down the heart rate as appropriate. You'll talk about that more when you talk about thorax in the next block. So next we'll start talking about some of the viscera that are present in the neck. What I'm showing you here is the thyroid gland, and notice it is this butterfly-shaped gland that is in the anterior neck, anterior to the trachea. The thyroid gland is, the isthmus is located from the second or third or fourth tracheal rings. So right here is the isthmus that connects the two lobes, the left and right lobes of the thyroid gland. The gland secretes thyroxine and calcitonin, which regulate metabolic rate and calcium levels, for instance. The structure is covered, though, in pretracheal fascia. And this, it is inferior to the thyroid cartilage, which is here, and the cricoid cartilage, which is here. In the case of a tracheostomy, that is when we create an opening near the second or third tracheal rings to provide an airway, for instance, the isthmus has to be moved out of the way. And so that's something that we have to be aware of clinically. If there's an enlargement of the thyroid gland, as is the case sometimes for hypothyroidism, so a lack of production of the thyroid hormone and calcitonin, what happens is that there tends to be a hypertrophy, so an overgrowth of the thyroid gland as a result in an attempt to make more of that hormone. As you might imagine, enlargement of the thyroid gland can compress the trachea, making breathing difficult, but also the esophagus, which lies immediately deep to that, can also be impacted, resulting in dysphagia. A goiter is another example of a condition in which there's an enlargement of a thyroid gland. And one of the leading causes is due to an iodine deficiency, where in some countries, they maybe don't have iodized salt, for instance, which then supplements the iodine levels in, let's say, developed nations, resulting in a decreased incidence of goiters in developed nations. Notice here how, so here's our thyroid gland here again. And then notice the connection or the close approximation to the carotid sheath and the structures, the carotid artery and internal jugular veins therein. So hypertrophy of the thyroid gland can also impact or compress the carotid arteries or jugular vein, internal jugular veins, also impacting the flow of blood to and from the head. The recurrent laryngeal nerves are shown here, which are branches of the vagus nerve. So compression of these nerves in a hypertrophied thyroid can result in a hot potato voice, is the way it's termed, because the recurrent laryngeal nerve and its branches are responsible for innervation of the muscles of the larynx. Because the thyroid gland embryologically begins near the posterior aspect of the tongue and then descends to its final resting place in the anterior neck, thyroid tissue may be found anywhere along the way. So the thyroid gland is guided to this resting place by this thyroglossal duct. And so anywhere along the path, you may find accessory thyroid tissue. You may also have a pyramidal lobe, which again is the result of the movement of this thyroid gland embryologically to its correct place. A thyroglossal duct cyst is also one of those clinicals that you'll see in your textbooks, and you're going to want to pay attention to that. Blood supply to the thyroid gland is through the superior thyroid artery, which is a branch of the external carotid artery. It's responsible for 20% of it, but the bulk of the blood supply to the thyroid gland is due to the inferior thyroid artery. The inferior thyroid artery is a branch of the thyrocervical trunk, which came off the right and left subclavian arteries, respectively. In about 10% of people, there is a thyroidema artery, And that's important because if, for instance, you need to do a thyroidectomy, you need to be aware of whether or not there is a thyroidema artery that is contributing to the blood supply of the thyroid gland, and you'll need to make sure that that is clipped and not allowed to remain open as you remove the thyroid gland. The venous supply is through the superior thyroid veins, which are that is from the internal jugular vein, the middle thyroid vein shown here, and notice the deviation of the pattern that you have in your notebook. So go ahead on and put an X here, because the pattern that we want you to remember is that the inferior thyroid veins drain into the right and left brachiocephalic veins, mimicking more of the bilateral nature of the inferior thyroid arteries, as opposed to both coming off of the left brachiocephalic. So again, to recap, the inferior thyroid veins drain into the right and left brachiocephalic veins, respectively. In terms of the nervous supply, the nerve innervation, right? So here's our vagus nerve, and vagus nerve is in the carotid sheath, traveling through the neck between the carotid arteries and the internal jugular vein. The vagus nerve sends a superior laryngeal nerve, which then has an internal and external branch. The internal branch pierces this thyrohyoid membrane, and that is the big clue as to its identity. The internal laryngeal branch of the superior laryngeal nerve pierces the thyrohyoid membrane to provide sensory innervation in the larynx above the vocal folds, which are located deep, or the vocal cords, is located deep to this thyroid cartilage. The external laryngeal branch is a motor branch as opposed to a sensory branch, and it innervates a small muscle here between the thyroid cartilage and the cricoid cartilage, called the cricothyroid muscle. And its action pulls on the thyroid cartilage, tilting it anteriorly so you could, for instance, hit a high note. The vagus nerve also gives off the recurrent laryngeal nerves. Notice that where it comes off is slightly different on the right and left, because on the left it goes around the arch of the aorta. And so the recurrent laryngeal nerve then goes up and provides motor innervation. It changes names at the posterior border of the cricoid cartilage to become the inferior laryngeal nerve. And so the inferior laryngeal nerve provides motor innervation to the muscles of the larynx for phonation. Please note that you may also see that action attributed to the recurrent laryngeal nerve itself. But when, I try to tell you when things are inconsistent in the text. And so if inferior laryngeal nerve is an option, I need you to know that that nerve is responsible for motor innervation to the larynx. Also on this image are the lymph nodes associated with the neck. Notice pretracheal and paratracheal lymph nodes shown here. Associated with the internal jugular vein are going to be deep cervical lymph nodes, different groups of deep cervical lymph nodes, primarily a superior deep cervical lymph node and inferior deep cervical lymph nodes. These are a group of nodes that receive drainage either more superficially regardless, they end up, all of the lymph will end up in inferior deep cervical lymph nodes, and then we will talk about the subsequent path in a second. Anterior to the cricothyroid muscle is this prelaryngeal lymph node, as well as a pretracheal lymph node anterior to the trachea. And then these paratracheal lymph nodes are here. Each of these drain laterally to these deep cervical lymph nodes, which I told you were associated with the internal jugular vein. So for instance, an infection on the vocal cords may drain to the prelaryngeal lymph nodes, which might then drain laterally to the superior deep cervical lymph nodes, and then inferiorly to the inferior deep cervical lymph nodes, where they will go through the jugular lymph trunks to the right and left venous angles. For the thyroid gland, lymph vessels are located in the interlobar connective tissue. And then they travel through a capsular network of lymph vessels to get to either prelaryngeal, pretracheal, or paratracheal lymph nodes. From there, some of them, the more superior of them, go to the superior deep cervical lymph nodes. And then the more inferior ones may travel directly to the inferior deep cervical lymph nodes. Regardless, all of the lymph in the neck ends up in inferior deep cervical lymph nodes before traveling through the jugular lymph trunks to the right and left venous angles via the right lymphatic duct or the thoracic duct. And then your notes have a small deviation that happens a small percentage of the time. Next, I want to talk to you a little bit about the thymus. The thymus, there is some embryo that is associated with this, and I will post a link to a video that can help you to understand what we mean by pouches and arches, because that has historically been on the shelf exams. The thymus lives in the anterior neck, well, not anterior neck, I'm sorry, in the thorax usually, immediately superior and anterior to the heart. It is largest in the neonate, and then it atrophies after puberty and involutes, where the tissue of the thymus is then replaced by fat. It is the site of T cell maturation. And so the T cells are made in the marrow, and then they travel to the thymus to get educated. I'm using air quotes that you can't see right now, but they travel to get educated in the thymus. After the thymus atrophies, then T cells may move to the spleen, tonsils, or lymph nodes after being made. It is located in the superior mediastinum, so that's about above the level of T4, but in the thorax. So T1 to T4. And so it comes from an embryologic, it develops from an embryologic place called the third pouch. There are a couple of diagrams towards the end of the notes, but I will again post a video describing how that third pouch comes about. The blood supply is the internal thoracic artery, and maybe a small contribution of the inferior thyroid artery, which came from the thyrocervical trunk, just like we talked about with the thyroid gland. Posterior to the thyroid gland are these parathyroid glands. It is a group of somewhere between 4 and 8 glands, typically 4 parathyroid glands that are absolutely essential for life. And so they must be located prior to the removal of the thyroid gland. They make parathyroid hormone, and the lack thereof causes muscular spasms or nervous excitability, tetany. It is derived from so the inferior parathyroid glands are derived from the third pouch, just like the thymus gland. And the superior parathyroid glands derive from the fourth pouch. And so again, we need to make sure we locate the parathyroid glands prior to removal of the thyroid. They're going to be difficult to see on gross dissection because because of the coloring, it kind of blends in a little bit with the thyroid gland. So that may be difficult for you guys to see as you are moving through your dissection. Here is the esophagus. This is a posterior to anterior view. So here's your esophagus and the inferior pharyngeal constrictor here. Okay. The blood supply to the parathyroid glands is through the inferior thyroid arteries, the right and left inferior thyroid arteries, again, branches of the thyrocervical trunk. The subclavian artery can be divided into 3 parts. Coming off of the first part, we have the common carotid artery, the right common carotid artery, the vertebral artery. Immediately behind the origin of that, you can find that stellate ganglia from the sympathetic trunk. The internal thoracic artery, which is descending into the thorax, and then the thyrocervical trunk, which we've talked about before, that gives off a major branch for that, which descends toward, travels toward the midline as it ascends, is the inferior thyroid artery, responsible for the majority of the blood supply to the thyroid gland. Also coming off the thyrocervical trunk is this deep cervical artery, and then a varying distribution would be the transverse cervical artery, which has a superficial branch and a deep branch, or sometimes this deep branch comes directly off the subclavian itself and is often referred to as the dorsal scapula. So recall that we're talking about the same artery when we're talking about the dorsal scapular artery or the deep branch of the transverse cervical artery. You'll also see the suprascapular artery and a varying consistency, I guess, coming off of this second part is the costocervical trunk. Now, the costocervical trunk sends off the supreme intercostal artery, which goes to the first or second intercostal spaces. And then there is an ascending branch, which is the ascending cervical branch, which anastomoses with a descending branch off the occipital artery, which is a path for collateral blood supply in the event that the external carotid, for instance, is occluded for whatever reason. Coming off of the common carotid artery, we have it branches or bifurcates into an internal carotid artery, which gives no branches inside the neck, but rather travels through the carotid canal to get within the cranial vault in order to provide blood supply to the brain. And then the external carotid gives off that superior thyroid artery, responsible for 20% of the blood supply to the thyroid gland. And then the lingual artery, which goes to the tongue, gives off some branches in the tongue. Superior to that would be the facial artery, which travels over the posterior border of the mandible to give the inferior labial to the inferior lip, the superior labial to the superior lip, and the angular artery towards the angle of the nose. Close to the bifurcation, you also see the ascending pharyngeal artery posterior to the external carotid artery. So the ascending pharyngeal artery is shown here, which gives branches to the pharyngeal constrictors in part. The occipital artery is shown here, and the posterior auricular is right here. There's a maxillary artery, which gives off lots of branches that we will talk about when we talk about the infratemporal fossa. So that space where our inside the jaw, there are lots of branches there that we will become intimately aware of. And then the transverse facial artery is here. And finally, the superficial temporal artery, which is a terminal branch of the external carotid artery. Is that right? Okay, so at the bifurcation, you'll notice a dilated part of the internal carotid artery, which is the carotid sinus. And located in the carotid sinus are baroreceptors, which monitor blood pressure. Is innervated by cranial nerve 9 and 10, so glossopharyngeal and vagus nerve. There's also a clump of nervous tissue posterior to the carotid sinus called the carotid body. And that carotid body contains a chemoreceptors, which measure oxygen and carbon dioxide, and is innervated also by glossopharyngeal and vagus nerves. The rest of these branches we've already talked about, so I won't belabor that point. But carotid sinus syncope is also one of those clinicals that you're going to want to make yourself aware of. In terms of venous blood distribution, notice that the internal jugular vein is here. Remember, we found that deep to the sternocleidomastoid, yet within the carotid sheath, and the external carotid vein, the external jugular vein was superficial to the sternocleidomastoid, much smaller than the internal jugular vein. So why don't we start up here with the superficial temporal vein? That superficial temporal vein drains into, combines with the maxillary vein to create the retromandibular vein. The retromandibular vein has an anterior and posterior division. The posterior division, together with the posterior auricular vein, form the external jugular vein. And then the anterior division of the retromandibular vein combines with the facial vein, which drains the face, and combines with the internal jugular vein here often. There is sometimes inconsistently a communicating vein between the facial vein and the anterior jugular vein. And I have here drawn in a red danger area of the face. So an infection on this portion of the face will drain through the venous supply potentially through the facial vein and to the internal jugular vein, where it can get into the blood supply. The external jugular vein, again superficial to the sternocleidomastoid, covered in fascia, makes it such that if there's a penetrating wound of the external jugular vein, it does not readily collapse on itself, and pressure needs to be held because of the fascia that maybe holds it patent. And so if it remains open, it can result in an air embolism. In terms of lymphatics, there's a superficial ring of lymph nodes that go around the mandible and over towards the occipital part. I've drawn these in yellow here. They include the occipital nodes, the superficial cervical nodes, the parotid and submandibular nodes, and the submental nodes. Superficial blood vessels, particularly those that are shown here, but also those that are closely associated with the external jugular vein. All of these superficial lymph nodes, the drainage varies significantly. Regardless, the lymph drainage ends up going towards the deep cervical lymph nodes, which I've told you are associated with the internal jugular vein. So the superficial lymph nodes are associated with the external jugular vein, as opposed to the deep cervical lymph nodes associated with the internal jugular vein. Regardless of where these originate, they make their way to the deep cervical lymph nodes, which are the superior and inferior deep cervical lymph nodes associated with the internal jugular vein. All of them drain eventually to the right and left venous angles via those jugular lymph trunks that we've already discussed. And then this picture shows you the same thing again. So just some things to think about. If there was a knife wound to the submandibular triangle, what would you injure? If there's an injury to a nerve that innervates the inferior belly of the omohyoid, what would you impact? What's the posterior scalene innervated by? If you had a puncture wound just to the left of the midline at C6, what would you be hitting? Which structures are most at risk during a thyroidectomy? And then in thyroid cancer, what's the likely path that the metastatic cells might travel in? So those last questions are all just to get you to think about what we've covered in this quite long now video. So that's it.